Hi, my name is Jamie Aranda, and I'm going to be talking to you about clinical pathway development for the emergency department. Regarding disclosures, the suggested resources are my own recommendations and not reflective of SAM endorsement. And the example clinical pathways shared in this lecture are under continuous review and subject to change. They may not be the most up-to-date or applicable to your site. Objectives today will include describe the evidence for clinical practice guidelines and clinical pathways, list some of the reasons physicians do not follow clinical practice guidelines and clinical pathways, describe some tactics to encourage pathway compliance, understand how to address a clinical problem using a pathway, provide examples of scenarios that would benefit from a pathway. Next, we'll talk about the evidence for clinical practice guidelines and clinical pathways. What is a clinical practice guideline? Clinical practice guidelines are systematically developed statements to assist practitioner and patient decisions about appropriate health care for specific clinical circumstances. They are the link between evidence-based medicine and clinical practice. They are not necessarily a fixed protocol. Clinical practice guidelines identify and describe generally recommended courses of intervention, but are not a substitute for the advice of a physician. Clinical practice guidelines are great, but do you have time to read this on shift? Some of these documents are around 20 or 30 pages, but some of them are 175 pages and can be particularly challenging to reference on shift. What is a clinical pathway? Clinical pathways are structured, multidisciplinary care plans used by health services to detail essential steps in the care of patients with a specific clinical problem. They aim to link the evidence to practice and optimize clinical outcomes while maximizing clinical efficiency. They are a tool used to operationalize best evidence recommendations and clinical practice guidelines into an accessible bedside format for healthcare teams. They promote standardized evidence-based practice, patient safety, and health system efficiency. So what is the difference between a clinical practice guideline and a clinical pathway? So we can take this guideline from the American Society of Colon and Rectal Surgeons, clinical practice guidelines for the treatment of left-sided colonic diverticulitis, and we can transform that in something that's much more accessible on shift. There are different types of clinical pathways. Operational pathways, some examples of those are agreements you may have with other services or ancillary staff. They may focus on admission or capacity management, process and communication, or basically just how to get things done and the logistics involved. Clinical decision-making pathways guide workup or treatment for certain common or high-risk complaints and diagnoses, help us meet certain quality measures, include evidence-based medicine. As you can imagine, most clinical pathways involve both operational as well as clinical decision-making components, and there is significant overlap between the two. What is the evidence for clinical pathways? So there was a Cochrane review of 27 studies, almost 12,000 participants, comparing clinical pathway use versus usual care. And the study showed a reduction in in-hospital complications, improved documentation. There was no evidence of differences in readmission to the hospital or in-hospital mortality. Length of stay was the most commonly employed outcome measure, with most studies reporting significant reductions in length of stay. There was a decrease in hospital costs and charges also observed, which favored clinical pathways. The author's conclusions were that clinical pathways are associated with reduced in-hospital complications and improved documentation without negatively impacting length of stay and hospital costs. So we know there's good evidence for clinical pathways, but why don't physicians follow pathways and clinical practice guidelines, and what tactics can be used? I like this figure because it shows the different barriers to physician adherence to practice guidelines in relation to behavior change. The first is a lack of familiarity, the volume of information, time needed to stay informed, and essentially guideline accessibility. Some of the tactics I use to make sure that our physicians are aware of certain clinical pathways is through an orientation session when they first join our group. I do frequent updates for our residents at our grand rounds and weekly conference. I also present this information at our faculty meetings. We send out regular operations updates every month with links to updated clinical pathways so that our physicians can reference them if needed. I also maintain an emergency medicine webpage with the most up-to-date versions of our clinical pathways. And finally, we are working to embed many of our pathways into the electronic health record in the form of order sets, order panels, discharge smart sets, and other resources. As far as lack of agreement with the guidelines in general, a lot of times physicians will express that clinical pathways are too cookbook or they're very rigid and they don't apply to their patients, that it challenges their autonomy or the art of practicing medicine. And so I think it's really important that anytime you send out a clinical pathway that you also include the messaging and the rationale behind it. At our institution, we use the SBAR messaging, which is situation, background, assessment, and recommendations. I will also include references to journal articles or the actual clinical practice guideline in the pathway so that if people want to look at the evidence, they have access to that. Additionally, we include disclaimers, so not every pathway is meant to be a protocol, and you should also continue using your clinical judgment. As far as lack of motivation or inertia in previous practice, following your old habits, following your old routines, I do think this is probably one of the most challenging barriers to address. I often will just communicate directly with my colleagues, so if we are on a clinical shift or we're having sign out, a lot of times I will use that opportunity to review some of the clinical pathways that we have and show how it may benefit some of the patients that we're signing out. In addition, I often receive feedback from other specialties if our physicians have not followed our clinical practice guideline or pathway that's agreed upon. So I will sometimes reach out to those individuals and find out if they even have awareness of the pathway or why they didn't decide to follow it in that particular instance. And this can be really enlightening as far as improving our clinical pathways as well as educating our physicians. Additionally, there is kind of this concern about reconciling the pathway recommendations with the patient preference. And I find this particularly true for some of our pathways that address things like chronic pain or that might be particularly challenging in the emergency department. And so in those instances, we have provided some scripting for some of our pathways that might be challenging to reconcile with your patient preferences. In addition, I think it's important that if all of the physicians in the group are following similar guidance, that there's consistency and our patients can expect the same care when they come in. That can also help address some of those hard to reconcile pathways. Finally, a perceived increase in malpractice liability. Again, I did demonstrate previously the evidence supports the use of clinical pathways. However, I think it's really important to establish good outpatient follow-up with your specialists, and making sure that you are always following the best evidence will help mitigate that risk. Next, we'll talk about pathway and protocol development and how I do it. So first, how to make a pathway. It's important that you define the problem that you are trying to solve. A lot of times people will bring new technologies or devices that they want us to start using in the emergency department, but it may not necessarily provide any significant benefit or solve any of the problems that we are trying to address. I think next it's important to interview the frontline staff and determine what existing barriers there are and what is needed to actually solve the problem. I will often review the existing literature, including those clinical practice guidelines, which may not be within the specialty of emergency medicine. They may be specialist guidelines. Next, I will identify different stakeholders and content experts, often within our department, who have a special interest in a particular subspecialty or are knowledgeable on a certain subject. And then I will piece together the process, and I often will just use a draft with pen and paper. And then finally, you must be open to significant edits and changes because the first draft may not actually be what you end up using. So here's an example of somebody's draft process here that they've written out. I will mention that there is convention followed when creating these flowcharts and diagrams, and I do try to adhere to that if possible, but I recognize that not all of the shapes are conducive to fitting all of the references and text that we sometimes need, and so I'll just mention that here. How to make a pathway continued. So you also need to ensure that you have all the necessary components, and I did mention earlier that we try to embed stuff in the electronic health record so people aren't having to navigate away to web pages or different sites. Oftentimes we'll create an order set or an order panel. A discharge smart set can be really great because you can auto-populate return instructions, specific prescriptions if needed, referrals to our colleagues in other departments, as well as follow-up locations. Sometimes we'll even prepare letters for work or return to sports, etc. And then I like to use an electronic program. There are lots of them out there. OmniGraffle or Visio are commonly used programs that you can use to assemble your pathway. And you always want to make sure it's in a logical flow and a visibly appealing format. I do get feedback from people regarding colors and whether or not they find it easy to follow. I do always vet my pathways with our emergency physicians and different content experts and medical directors. And don't forget to ask the residents, PAs, and nurse practitioners because they are often the ones that might be, especially in an academic center, the initial person to see a patient, and so they are often placing orders and have good, insightful feedback as well. Don't forget to set a go live date for communicating your pathway with joint messaging to different groups. An example pathway, so first we'll define the problem. So patients referred to the emergency department for idiopathic intracranial hypertension workups are time-consuming and labor-intensive, involving lots of phone calls, procedures, diagnostic studies, and labs, etc. So the barriers are that there are multiple specialties involved, lots of different recommendations from different consultants, and lengthy ED visits. What's the workup? What are the red flags? Who needs an LP? These are all things that you can find in the literature. Identifying stakeholders. So in this case, I'm reaching out to ophthalmology, neurology, possibly our observation unit as a place for these patients to get their workups. Next, I'm going to create a draft pathway. So in this particular pathway, you are not meant to be able to read the text, but I am going to point out some features here. So first, you definitely need to include like a date or a revision history. This can be really important to reference when you have agreed upon pathways, and also just to make sure that you're reviewing on a regular basis. Next, you want to make sure that you include some evidence-based materials in there. So in this case, we have features of idiopathic intracranial hypertension, including some things that could be normal and not necessarily rule out that condition. I also included some red flags that should alert the physician to either exit the pathway or escalate their workup. I have included some recommendations as far as the exam elements and a standard acceptable workup. And then finally, a disclaimer there. So not every patient is going to fall into this particular pathway, and we definitely need to be using our clinical judgment. So what makes a good pathway? A good pathway must be easy to follow. It should address a specific problem, such as improving the care in a certain scenario. It should make the emergency physician's job easier and not impose additional barriers, or else people will not use the pathway. Should be supported by evidence. And for pathways promoting discharge from the health system, you really need to prioritize close outpatient follow-up and good return instructions to avoid liability as well as patient safety events, and to keep our patients safe in those scenarios. And for pathways expediting admissions, it's really important to get our consultants on board to buy into the process. I do have an example demonstrating that, our hip fracture pathway. So again, I'm not intending for you to read all of the small print, but you can see here everything fits nicely on one page. So patients presenting with a low energy hip fracture, we tend to expedite our workup. We do have an order panel for the images. And then once a fracture is identified, there's additional order sets as far as testing that should be done for specific labs as well as different medications. And then we also will consult our anesthesia colleagues for a nerve block or perform it ourselves in the emergency department. The different services do have to sort of not sacrifice, but make some concessions to the other services. So our orthopedic surgeons will admit the patients, and they will also follow up on the bone fragility labs. Our emergency medicine colleagues will use the order set, appropriate images, and page the appropriate services. And additionally, we have agreed to complete some of the pre-op questions as far as their last PO intake and when they last took their anticoagulation if the patient's anticoagulated. Internal medicine completes a pre-op evaluation but does not admit the patient. Anesthesia is involved for planning and communication, and then our regional pain service will perform a regional block in the emergency department. Just wanted to review a couple of scenarios that really benefit from clinical pathways. One is anything that involves a complicated workup or follow-up where you feel like you're constantly having to reinvent the wheel when you're trying to arrange their discharge and you're trying to get them their rabies vaccine series, or plug the patient in with neurology so they can get an MRI and an EEG and a neurology consult, etc. Another category that benefits from a clinical pathway are common complaints, certainly things that are key ambulatory conditions that have specific metrics that we need to follow. And additionally, high-risk complaints or things where you need to have access to important information in a timely manner. Pearls of clinical pathway development are to allow for individualized care and physician clinical judgment, err on the side of safety, and use evidence-based medicine, and include data where helpful, such as level of evidence as well as risks. Thank you very much.